I just wanted to let you all know that our speaker is a little delayed. As soon as he gets here, I'll introduce him, Dr. Dong, and we'll get started. Okay. You can go ahead.
All right, sounds good.
Okay, we are back after lunch, and it's my pleasure to welcome Dr. Brian Dong. He's a breast oncologist for U of L Health Brown Cancer Center. Dr. Dong received his Bachelor of Science degree from Duke University prior to graduating from the University of Louisville School of Medicine with his Doctor of Medicine degree.
True.
After graduating, he completed an internship with the University of Louisville Department of Internal Medicine, where he also completed his residency. Dr. Dong then went on to complete his fellowship with the University of Louisville Medical Oncology and Hematology. At the Brown Cancer Center, Dr. Dong specializes in medical oncology and hematology with special interest in high-risk breast disease, breast cancer genetics, breast cancer adjuvant therapies, and metastatic breast cancer. He is certified by the American Board of Internal Medicine. He's a new board member of Twisted Pink. So welcome. Thank you for being here.
This mic works, right? Yeah. Okay. Sorry for being a little late, everybody. Hopefully, a little more time for lunch is never a bad thing. And sorry I have a mask on. I'm recovering from a viral thing, but don't worry, I didn't eat any Taco Bell recently, so don't have to worry about that stuff. I guess I'll report. But thanks everybody for being here. So I'll talk a little bit about ctDNA and its use in breast cancer. I tried to tailor the talk to kind of a general overview. I mean, obviously there's some data in here, so for the other medical oncologists here, it'll probably be a little boring, so I apologize. But I do think there's some interesting discussions, especially when we get into the MRD screening set of the talk. So let's get going here. Or here, let's see. All right. So just some disclosures here, and then, I figured it'd be funny to say, when you're doing PowerPoints now, apparently there's like a design suggestion, and it's really tempting to click it and make it look really pretty, but I resisted temptation. So, I try to make the slides more boring, so hopefully you listen to what I say. I guess that's always been my tactic, but if you guys nod off right after lunch, it's okay. I don't blame you. I might do the same. No, I'm just kidding. All right, so a little bit of outline. So, I think when you think about ctDNA, you have to think about, targetable mutations and, target-specific treatments that, not every patient qualifies for. And then the flip side of this, like I kind of mentioned, is MRD in terms of, who's going to be a better responder to the therapy, and then in the future, maybe who needs more therapy, who needs less therapy. That's certainly high-hanging fruit that hopefully we get an answer to, sooner than later. So I'll dive a little bit into that. Okay, so, in terms of NGS, next-gen sequencing, I think most of us are, at least somewhat familiar with this concept. The way I describe it to patients is we're trying to personalize your treatment to the cancer that you have. So, we've known about the human genome, cancer genome for many years now, and, as you can imagine, we have, a lot of different tests to look for these, specific mutations that can, qualify you for new therapies. And, if you guys have seen the viral videos from ASCO, there's a standing ovation for the pancreatic cancer drug with the KRAS mutation. So this is certainly a hotbed of, research across a lot of tumor types. And, you never know when the next breakthrough is going to come through. So certainly EGFR and lung cancer has been a huge thing over the last, 4 or 5 years. And then, KRAS, and then certainly for breast, PIK3 is a major target as well. And then, obviously you can do this analysis on solid tumor biopsies. So, you biopsy a lung, a lymph node, liver, something like that. But also, certainly with newer technology over the last, I would say 8 to 10 years, we can do it on blood as well, which is, certainly a lot easier on the patient. I guess in years past, there's been like 40 high schoolers here, so I try to, like I said, give some, more simple slides here. So sorry to the more familiar people here, but, like I said, you can do DNA and RNA in-depth analysis on tumor tissue. And, from a workflow standpoint, you see a patient in your clinic, and you order it. It can take 3 to 4 weeks to get the results back. But, I think classically you would think, solid tumor testing is a little bit more sensitive for picking up mutations. Some of our colleagues in other tumor types like to send both at the same time, which I think is, reasonable as well. And I think I have a figure coming here too. But when you do liquid, obviously you're trying to pick up circulating tumor DNA being shed by a primary tumor in the blood. And, I think probably 20 years ago, that was something that was just a fancy thought. And then, it's kind of cool that we have the technology now to reliably detect this and do testing on it. All right, so, sometimes it's easier to have some photos up here. So, this is from a review, I think, a couple years ago, where it's very simple, right? So you do a peripheral blood draw, which, you can do at any clinic office. You put in a certain tube and you send it off to your company of choice. I think a lot of bigger places, I would say, have probably the internal testing too. So you're looking for, the specific circulating tumor cells, and then you run your analysis and you hope for, actionable mutations, right? And then, just to kind of contrast with, sequencing on a solid tumor cell, certainly you have a little more, I would say, information in depth of analysis that can be done, although, truthfully, I'm not the best person to tell you about all the microbiology that goes into this step. But when those companies come around, they will talk to you for hours about this if you have the time. So certainly a constantly evolving field in terms of, maybe sensitivity of how minute or how low frequency mutations that we can find that hopefully have clinical significance. So anyway, this is just a fancy slide to say that obviously this is a complicated process, but, there is clinical translation, fortunately, now. And then, I thought it'd be helpful. This is like just I Googled this generic name, so I don't believe that's a real patient. What a report looks like. So, I think the companies have figured out bolding, colors, check marks. These are things that stand out more to patients and, maybe make it as easy as possible for the provider to decide if this is actionable or not and what drug we can do about it. And then, interestingly too, you see the, circulating DNA amplification percentage there. So, there is a question sometimes that the number's 0.1. Is this something that's going to be significant? And, that's, I would say, is in some debate depending on the company they're using, the testing they're doing. But from a clinical standpoint, there's a chance of an actual mutation. My preference would be you have to give them a chance to see how it goes. I don't think I put on here, but there's usually a page. These reports are like 30, 40, 50 pages long. So they'll put, all the mutations they test for, and it's usually a little bit overwhelming for the patient to see. So, usually that front page, just give them, the overview is the most helpful. So, to kind of put it more relatable to breast cancer, I'm really just going to talk about two. So that being the PI3K pathway, along with AKT, mTOR, PTEN, all that, and then obviously ESR1 as well. And, my idea with this was not to get too far in the weeds. I mean, I'll say some of the trials up just for, I guess, context. But really, I think the more interesting part of this for me is more the second half of ctDNA, but we'll go through some of the relevance here. I think we're all somewhat familiar with, estrogen receptor causing, tumor proliferation. About 70-75% of breast cancers are going to be estrogen positive. So, it's always nice when they put the drug to the target that it's inhibiting, although this is, I would say, a little bit on the simplified side of things, if you can believe it or not. But I would say there's kind of two pathways here for resistance. You think directly at the receptor, where certainly an ESR1 mutation can make a difference, and then you have the PI3K, AKT, mTOR pathway on the right there. That's kind of like I would say, a mechanism of estrogen resistance in a tumor cell. So, they get some nice colors here and makes it a little more easy to piece out. But certainly in terms of the drugs, I think a slide in 10, 15 slides where it's a little bit more hashed out in terms of drug options available, or at least being researched. Oh, it's literally the next slide. Okay, so, sorry, I finished a couple of these 2 days ago. This is, an overwhelming slide, but it's meant to, give you some hope that there are a lot of new constructs, drugs being developed for these different targets. Some of these you may recognize, and I would say gedatolisib on the left there in the blue box has gotten a lot of play in the last week with its approval. So that's something I would say exciting. I'll touch on a little bit later here too. And then if you look on the right, some of these drugs don't even have a name yet, right? LY30214, my goodness. So a lot of these things are in phase 1 trials, as we're talking right now. So it'd be very interesting to see what the future of this pathway looks like. But certainly, as I tell my patients, a hotbed of research here. So let's see, I think this is what I want to cover here. Okay. It's July, so we just had another batch of new fellows come through. I think you guys may have some similar to your other institutions. I always feel bad trying to talk them through the first time this pathway, and truthfully, this chart changes, every 3 to 6 months really. And then it comes down to personal preference too, right? I mean, I think, even just locally, I've had some, we'll say, fun debates with some of the other oncologists here, which is good. I mean, this is something where, I would say from a physician standpoint, the more information you give me, or the more data we have, the more options we have, the better we can treat our patients, and, the better we can have shared decision making. But it's not straightforward, right? It's not A, B, C, then D. It's a little bit more, truthfully, there probably should be more arrows on this thing going back and forth, right? So I think, the way this PI3K and ESR1 pathway is developed, fortunately, they're trying to move earlier and earlier in their therapy. So the question is there a certain patient where you would use it first in combination with other standard of care? Is there someone that should get a second? And then, obviously tolerability. So what's the best sequence for that? And truthfully, I don't think we have the full answer. But certainly it is a very, juicy doesn't feel like the right word, but it's a very meaty topic to discuss, right? So I'll go into an overview of some of these things. I mean, I was really trying to not make this just, data regurgitation. Then I made these couple of slides, and I was like, I did exactly what I was trying to avoid. But unfortunately, when you're talking about some of these things, you need this foundation. And in 4 days, I'm giving the ER positive talk to the fellow, so I'm just going to copy and paste some of these over. But, I think a lot of us are familiar with at least the first couple here. I mean, probably all of these. So, SOLAR-1 with alpelisib, certainly the first, I would say, PI3 kinase to have clinical significance. And, this is from before we even widely use CDK4/6 in the front line. So they had to follow it up with the BYLieve trial, where they did alpelisib plus, some type of anti-estrogen therapy after CDK4/6, and PFS was still held. So I think this is a reasonable second-line option, but I think anyone that's dealt with these drugs and these patients, it is very challenging to keep people on this. I mean, I would say for the first 5 years of my career, I probably attempted to get someone on alpelisib maybe 12, 13 times. I've only had one stay on it longer than a month. And out of those 12, 13 patients, probably 30 ER visits, for glucose of whatever number. Unreadable, So it's certainly an effective group of medications if patients can stay on it. I would say definitely improvement from the previous standard care with just, let's say, fulvestrant second line, but truthfully that's probably outdated now too. I think it'd be very rare for a patient to have monotherapy fulvestrant in the second line in 2026. But so you had solar and Byleave for alpelisib, and then certainly Capitella 291 was a big one for capivasertib or TrueCap. That's another fun drug to say, right? Hearing a doctor for 4 years as a first-year fellow say that word is kind of entertaining too, just FYI. But that's kind of mean, I guess. So there's data for targeting AKT, right? So downstream of the PI3 pathway. I know I didn't really highlight too much earlier on those color slides, but I would say another player into the space. And I remember when this trial came out, I had a patient that I was waiting for to the day to get on this drug. And fortunately, it was like December, I think 2024, 2024. We got her on it, and I would say, her outcome was significantly better than what the trial suggested. So that, great to see. And then, continuing the line of, interesting names of drugs, and alpelisib is another more recent player in the front line of therapy, right? So looking at this combo of alpelisib, palbociclib, fulvestrant in people with recurrent disease, I tell you, when I hear those drugs the first time, you're like, wow, that's a lot of things, right? I mean, how many toxicities we have to deal with? You're going to deal with metabolic stuff and cytopenias. But once again, the data is very encouraging in terms of, this is a more high-risk population, whether it's due to the PI3 kinase, whether it's due to their clinical course, higher burden disease, recurrence, maybe other sites, visceral disease, that kind of thing. But there was a clear benefit on the trial. And I think I have a slide on this a little bit later, but you got to remember that, these are pre-selected people with A1Cs less than, something between 6 to 7%. So a much healthier population than certainly what we have here on average in Kentucky. So, navigating this treatment course has been, an interesting learning experience for myself, and I'm sure for a lot of oncologists here. And then importantly, too, with Novel 120, there was almost a significant overall survival. So, to have that in estrogen-positive disease in a frontline setting is tricky, and that's a messier conversation, but I won't dig too far into it. But, I think that regimen is very, effective in people that can tolerate it, and certainly something you have to look for in someone presenting with current disease. Okay, sorry, a couple more dry slides here. So, in terms of pick 3, so you have these new drugs and, many more on the way. And you're trying to see what the best use of these is. So, you push it further and further up the line. So, Novel 123 is someone that's looking at patients that don't necessarily have to have recurrent disease, but they're frontline metastatic regimen, but they have a PI3 kinase mutation from the get-go. And then you do an alpelisib with a CDK4/6 with an AI. So, can they apply to more people? Certainly, when you look at these large trials, usually something like 40, 50% will be de novo. Most are recurrent, but it's a big need as well, right? Can I apply this to people that haven't had any treatment in the metastatic setting? And we'll see, right? And then also a Capitella 292, it's kind of the mirror of a Novel 120, where you're looking at people with recurrent disease, possible estrogen resistance, and you use capi instead of an alpelisib. So, there are a lot more of these trials out there, but selfishly, I picked the 2 that we have open here at U of L to kind of not toot our own horn per se, but just say that these are things, we're all actively looking at, right? We know this is a need for patients, for people with concern for, estrogen resistance. So, when these came across my email inbox, it was a respond immediately. And if there's anyone here that I don't respond immediately to, I'm sorry in advance. Okay, so I mentioned gedatolisib earlier. And sorry, I guess this is the more dry media part here, but it's a dual PIK3 mTOR inhibitor. So, we went to a slide 5 ago, whatever. It's blocking 2 different parts of the PIK3 pathway. So the major trial that just came out was the Victoria 1, and this is looking at a true second line in HR-positive metastatic patients. And they looked at triplet therapy versus doublet therapy versus monotherapy fulvestrant. So this is a very ambitious trial, my goodness. And they found PFS benefit compared to fulvestrant in both the triplet and the doublet. And then interestingly, that's in the intentional treat population, which was all comers. And then when you look at the PIK3 mutation, the triplet and the doublet actually had about the same PFS compared to control. And kind of make it a little tricky. The control is fulvestrant or alpelisib, not just fulvestrant. So certainly a little bit more convincing in terms of therapeutic benefit. And that was about 50% of the patients on this trial. I can't remember if I put in. Okay, here we go. Yeah. So. These are the Kaplan-Meier curves we're all very familiar with. And I believe the top is the triplet, the second one is the doublet. You can see very clearly there's a separation of the curves there. This is a trial they're going to have to follow out a little bit longer. Be curious to see, maybe not necessarily PFS2, but overall survival. But certainly a very exciting new drug. And I don't think I talked about toxicities here. Yeah, but If I remember correctly, I believe the incidence of hyperglycemia was like 8%, which is significantly less compared to alpelisib and capivasertib. So something that is exciting, but truthfully, for me, it's a grain of salt. I got to see some of my patients first and not have their sugar jump up to 600 or something before I believe it. These trial populations, if you take someone that's either completely not diabetic or barely pre-diabetic, it's a lot different than if someone's A1C is 8 or 9 and they're doing these things, right? So does that mean you shouldn't use them in these patients? I think that's the harder question, especially if you're looking at already progression on front line. You want to maximize the amount of therapies that can get there and prevent, doing chemo or something like that. Okay. All right, so you guys are probably, snoozing from pick 3 now. So let's move to ESR1. This is a little bit spicier of a discussion too. I mean, thinking about when Serena-6 came out last year and then the update this year, I remember watching on, the ASCO website, the virtual player or whatever, when Erica Hamilton was getting pelted with questions and people were feeling very strongly about, keeping options in the back pocket and all this stuff. I mean, it's a constantly changing space, right? So the discussion changes every 3 to 6 months. So I'm not envious of a fellow who has to come into this with no foundation. They have to build that and then add this, but part of it is exciting, part of it, is a bit of a challenge, right? So, this mutation is associated with estrogen resistance. And the interesting thing about it is that this can it can be developed over the course of treatment over the first couple of years. So I think it was something like on the Serena-6 trial, I think it was like 5% had the ESR1 mutation at start. And then it was something like a range of 20 to 40% of patients will get this over the next couple of years of their therapy. And then, of course, oral SERDs are all the craze. This is like taking over what we do now for the estrogen-positive space. And, there are multiple of these that have shown benefit in patients with ESR1 mutations. I don't think I put all the Kaplan-Meier's here. I feel like I was getting a little dry here. But certainly, elacestrant has data off the EMERALD study for second-line over fulvestrant. And then EMBER-3, imlunestrant showed benefit over fulvestrant. Interestingly, they didn't go for approval for imlunestrant plus abemaciclib. That's a discussion for another time. And then kind of separate from the metastatic setting there, lidERA trial also, I've been getting a lot of questions about this trial in terms of, am I ready to implement and that kind of thing. And, I won't dive too deep into that, but certainly it looks like they want a race of some sort with giredestrant, in the adjuvant setting, which did include, I think it was like 40% stage 3 patients. So, certainly plenty locally advanced, but I believe it is not commercially available yet, but probably will be before the end of the year. Okay, so, I think, it's hard to talk about ESR1 without talking about Serena-6. And, this definitely is a spicier trial trying to mix up standard of care for, majority of patients here. So they employed a switch therapy of changing from an aromatase inhibitor to a oral SERD, camizestrant, whenever you detect an ESR1 mutation. So they did a liquid biopsy every 2 to 3 months in every patient on this trial, which is, quite a logistical burden, I guess I would say. Not only just the testing, but also maybe financial burden. And then, let's see. Then, the main question I would say is, do you maximize your therapy up front, or do you keep it in your back pocket, since we know, based off several trials, that there's data for this in the second line? So do you blow through 2 lines up front, or do you do it sequentially? Which one's better? That's the question. So I think this is off the, either a podcast or something, or the New England Journal kind of press release or something. So, like I said, just testing every 2-3 cycles for liquid biopsy with ctDNA for ESR1 mutation. As soon as they detect it, then they randomize them 1-to-1 to either keep doing what they're doing or or replace their AI with camizestrant. And I think I do. Okay, good. Yeah. So here's the PFS slide from last year, where they found it was a difference of 16 versus 9.2 after you made the switch. So that's what caused some rumblings of excitement or discussion or discourse or whatever you want to call it. And then I think, okay, good. This year, the main thing was PFS2. PFS2, does it really matter if you're, should you burn through it up front? And, on the side, PFS2 is something that didn't exist when I was a fellow, and now all of a sudden it's a huge thing for estrogen-positive disease because the outcomes are so good, right? So following overall survival, it gets to be messy in terms of the sequence of chemos and any other, other combinations. So Now we have to look at PFS2, which I think is a good marker in the right setting. So they released data for PFS2 this year from Serena 6, and it was significant at 25.7 months versus 19.1. So I think the question a lot of people had a year ago has progressed a little bit. I definitely don't think it's standard of care now where everyone's making the switch. I think a lot of people still would prefer to, if someone's responding very well up front, continue that, because I think we've all had patients that have been on AI CDK4/6 for years. But I think personally for me, I'm starting to consider, maybe implementing this, at least trending for when the ESR mutation shows up. And, I've talked to, several of the NGS companies. They tell me they'll get it approved. Kentucky, we get a lot of Medicare, Passport, those kinds of more challenging insurances to work with. So personally, I'll be very interested clinically how that holds up. So I'm optimistic, but I'll believe it when I see it, kind of thing. Okay, so now I'm going to switch a little bit. I hope I'm doing okay on time here. Am I supposed to be done by 1:45? Is that the ish? Okay. Oh, I might have to go faster. Okay. ctDNA for MRD is, I would say, very much so a hot space, depending on the tumor type. Breast cancer, depending on the opinions of the people in the room or the opinions of the people in the city. Sometimes I get weird faces made at me and that kind of thing. So I say here, a hotly debated topic, and there are several different assays. I'm not going to go through all of them. I'll talk about a few of them, and the tears in the room too, which is kind of funny. So I just want to reiterate that I don't get any money from these companies. My experience is clinical, based on patients I've seen here. And truthfully, I think the interesting part at the end of this, I think I have like 4 or 5 slides of patients I have here and their trend of the ctDNA that I think will be probably the most fruitful to see out of everything I'm presenting here today. So before I dive into that, this is something I'm sure every provider has dealt with at some point, or more so recently, on these ctDNA cancer screening tests, right? The more generic ones that they're out of pocket, they're not FDA approved, Gallery and CancerGuard. I had some patients send me like a podcast from an internal medicine group that I can't remember the name of it, but it was a good podcast. And I think it was someone from like Mayo Clinic or something that's on these trials looking at these things. I would say I personally don't recommend these to patients. I get it if you have the means to drop $1,000 to get either peace of mind or a lot of anxiety. A lot of people are going to do that. I think this is, probably 5 to 10 years away at least for having more meaningful significance and not, medical system waste personally. But, certainly it's more of a hot topic. I didn't want to dive into all the data with this, but it's a growing space, and truthfully, it'll probably look very different in the next few years, and maybe another player will come into it. Who knows? We'll see. So anyway, I just want to talk about that real quick because that is a big part of, if I'm seeing, I'm sure everybody's seeing it. Okay. So Foundation has a ctDNA assay called Pathlight. It is tumor informed. They have the tracer study where they did retrospective analysis of people with early stage disease, and they trended them every couple cycles, and these are patients that got neoadjuvant chemotherapy. And their tagline at the end was like, hey, everyone that recurred did have a positive ctDNA reading. This is their chart to show it, and it's kind of probably really small up there. But if you look at C, D, E, and F, basically if you're positive ctDNA detected, those patients had a higher risk of recurrence essentially. You gotta remember, this is in 100 patients, and every time I talk to one of these companies, I say the same thing. Make it 1,000, make it 2,000. Why can't it be, Ladera's study was, several thousand, so why can't a ctDNA study be in the several thousand as well? And the tricky part is that you'd have to follow these patients for a long time, right? So then the cost of running that trial, and it's a much easier endpoint to just say, here's the trend over, say with chemotherapy or something like that, and then look at the next year or two as opposed to 5 to 10 years. Guardant has their Infinity test. This is tumor agnostic, so some would say that's advantageous. Maybe you don't have to spend as much time testing archival tissue, or maybe you can't find the archival tissue. And they basically, my understanding is they did a huge analysis on several cancer genes and came up with their algorithm. And they have a couple of different, I guess I'll say abstract posters. One of them they sent me was 95 participants looking at pre-op, post-op, and then kind of long-term follow-up. And they included triple negative breast cancer patients as well. And, no surprise, they found that if you had more aggressive tumor features, you're more likely to be positive. And, kind of showing the same thing here with the Infinity test. The yellow line on the left and then the yellow line and blue line on the right there, not the most, I guess, distinct there. But certainly if you're detected, then, your risk of recurrence is higher. But once again, this is, 98 patients or something. So, and if you look in the, A on the top right, really not looking at a ton of numbers there. I mean, you're looking at 51, 7, that kind of thing. So, that's kind of been the trend for a lot of these companies where there's a little bit, it's like a tease, but it hasn't been, I would say, prime time yet. But from a testing standpoint, their argument that there's enough there for clinical application. And I think I'll get into a little bit here, but for me, I basically took it upon myself to say, the data I truly want to get with these tests is probably not going to happen for a while, if ever. So I decided to get used clinically myself, truthfully. And, part of it is getting the test paid for. Part of it is managing patient anxiety and those kinds of things. And I'll get into it here a little bit here. But, all the data in the space looks pretty similar, right? So here's another same thing with Infinity and triple negative. Getting chemotherapy, so similar to the Pathlight assay. And they check it every few months or so before and after surgery. And, again, same thing. If it's positive, then associated with recurrence. And, it's not surprising if you look on the right there. If you have a non-PAT CR to your chemotherapy and positive ctDNA, pretty much all those patients recurred within a year and a half, right? Which I would tell you clinically, that would be your concern anyway, right? Maybe not within a year and a half, but certainly would be concerning. And, it's not a big group of patients, right? The start is only 6, but, I would love for that number to be 100, right? So I don't know if we'll ever get that, but ideally that's what I would like. And then, I'm getting, I think, to the end here. So in terms of Natera, once again, I don't get paid by these people, but it's good to see the team here. I know them very, very well, obviously. So I do like that this is tumor-informed, similar to Pathlight. The first draw takes like a couple months to get your result, right? Because you got to send off to their central lab and do their DNA testing. And then you can trend this with peripheral lab draws, right? And afterwards, subsequent draws take, 2-3 weeks to get results. And now they think they have a patient portal and all that stuff, so it makes it easier for patients to get their results. And, I would say as of now, they have the most data in different settings, not just neoadjuvant, but adjuvant as well. The cost so far for me has been, reasonable, I would say. The majority probably pay 0, but I've had a couple that get, these EOBs or whatever for up to 300. And, they have data in colon, lung, and breast, which I think is, they're a little bit ahead of the other competitors. Colon cancer, I would say, has a lot more buzz than us, right? So in terms of looking at people that were ctDNA positive after surgery, getting chemotherapy or not, they found that if you use a ctDNA-guided treatment pathway for chemo or not, it was non-inferior to just using clinical stage. So that was very interesting. And then same thing with, non-small cell lung cancer, trying to identify people that are more at risk for recurrence. I don't believe there's treatment changes in regards to lung cancer yet, but certainly, I think there's utility in a few different spaces. And then for breast, I feel like I'm kind of saying the same thing over and over here, but I-SPY 2 is definitely one of their big trials. As Gryphon, the other companies are having 100, they had 700 patients here across all 3 tumor types. And you look at ctDNA at the start, after, 3 weeks of chemo, 3 months chemo, and then at the end. And certainly trending to that clearance, I think, is, helpful information. So, this is kind of the overall, but basically you can imagine the ones that are the lowest, so it's the red lines and then the maroon line, with highest ctDNA levels throughout their treatment and had high risk of recurrence. And, like I said, the numbers there are certainly a lot more than just 6 or 10. You're looking at 240, 250, 130, which I think, helps add validity to the test and the study. Yeah, this is a small study in the UK. I think it was an abstract or poster. I want to say at ASCO or ESMO. This is looking at more just definitive of like, hey, at time of surgery, was there ctDNA left over or not? Which I tell you is interesting because, you expect that number to be pretty low. But I would tell you in my clinical practice, I have had several patients that were still positive after surgery. Not that it changed their adjuvant treatment or anything like that, but certainly may have inspired more compliance to treatment maybe. But, same punchline here. ctDNA positive patients after surgery had a higher rate of disease recurrence. Okay, so I think this is probably, sorry to make you sit through 30 minutes of the other stuff, but I think probably the more exciting part of this topic. So for me, in terms of who I use it on, I generally would say high risk. So how do you define that? Do you define it the same way as like, the Natalie and Monarch study, or, based on tumor biology? So, certainly someone that's had an incomplete response to neoadjuvant chemo, I would definitely use it on. Someone that has a high burden disease, inflammatory breast cancer, high nodal burden, or something like that, I would recommend it for. And then truthfully, there's the Facebook groups we all know about. There's Reddit. There are several patients that come to me, I'll say asking/demanding for these tests, which is fine. I think it's a fair discussion, right? So the more equipped they are, the better conversation it is. I don't recommend it to everybody, but certainly a fair amount. And my protocol really in the adjuvant setting is I'll check it every 3 months for the first year, then every 6 months afterwards, and then kind of list the same thing I just said there in terms of who I qualify for. And some that's based off the iSpy, some that's based off other trial data where they kind of do ctDNA testing alongside the trial regimen. And then when I, obviously preparing for this talk, I looked at my overview, whatever data insights on the thing. So I've had 76 patients tested total over the last, 3 years or so, 10 positive results. And, I kind of looked at the absolute value of the mean tumor molecules, and it was around 19 in terms of people at disease recurrence. I tell you, just with this, for whatever reason, patient population is mostly ER positive, triple negative breast cancer patients. And, the biggest feedback I get is, what do you do with this test, right? I mean, it doesn't change treatment at all. We don't have any data that, changing the lead time of diagnosis is going to lead to better outcomes. Maybe you just get more toxicity. And I totally hear that, right? I mean, that's totally a fair criticism. For me, when I had a couple patients that, someone comes in, let's say they have 4 to 6 lymph nodes, they get neoadjuvant chemo, they get their surgery, margins are clear, you get scans, it's all negative. And then I have a couple of those patients recur in 6 months. And when they recur, half their liver is chock full. And you're like, what in the world happened? They took the therapy, they finished all their chemo, they're on the hormone blocker. And basically after a couple of those, I just said, that's, if there's anything else that can help me prevent from being, a tumor going from 0 to 100 like that, I'm interested. So that's part of the impetus of why I started using it a little bit more. And, then it comes into what is the value of that ctDNA, right? So what is the MTM here? There's no real data for this, right? So in terms of it's not a doubling time with a PSA. So I would tell you, for me, I usually just trend it. If you think something's a false positive, you can always repeat it. If something is rapidly uptrending, I would tell you my experience is that is something you should pay attention to. Okay, so with that said, I think I'm almost done here. So I wanted to show some of my patients here and my experience with it. And, it's variable, which I think is good. It's fair. And you can look at my frequency of testing and that kind of thing. So this is actually a patient with stage 1 disease, but it's triple negative, and they had a genetic mutation. Very motivated patient on all the forums, posting at ASCO and all that stuff too, which is great. I'm not dogging on that. I'm just saying she's very, very motivated, and basically put me up against the wall and said, "You're getting this test." So she's stage 1, triple negative, did get chemotherapy, did great with it, and then of course her first ctDNA comes back positive. And I go, "What? Are you kidding me?" Reached out and said, "Hey, false positive rays, are real or not?" And I've been reassured, no, positive's positive. We repeat a few months later and it's back to 0. And that patient had a PET at the first time. Goes back to 0, exhale, we're good to go. Next one, June, boom, positive again. I'm like, what is happening? Clinically, this patient should have a 5 to 10 year survival rate of 95 to 97%. Should be very high, right? So this is a very surprising finding. Part of my theory at the time was maybe there's something to do with her genetic mutation that maybe was being detected, but that's doesn't quite make sense when you look at the science. And, you could argue my use of this caused her to get 2 extra scans that she didn't need, right? Totally fair criticism. And fortunately since, you can see I even checked it last 2 months ago, which means she probably has one coming up soon. But it's been negative since, right? So I think it's a good example for me, or for you to see how I use it in terms of looking at the overall trend. And this is obviously a very anxious person, but also demands her tests. You can see I've been doing it, every 6 months for the last couple of years, and she has been to the T, you got to call me as soon as it's back, that kind of thing. So there are pros and cons of that, right? But at the same time, it's triple negative. She has a genetic mutation. She's very young. Something were to come back, if there's something that can help me catch it as early as possible, I'm interested, right? But again, there are fair criticisms of this, and I totally accept it. Okay, this is someone with triple-negative breast cancer as well, and they had an incomplete, they did not have a PET CR to their neoadjuvant chemo. So to see that initial withdrawal was not a huge surprise. And then when it went to 0.7, I just said, hey, let's keep an eye on it. Looks like I checked one 2 months later, so kind of like a shorter term follow-up. When it went to 2, we repeated the scan and it was negative, and I just said, hey, look, like we'll keep an eye on things. And then I think they were lost to follow-up a little bit or something. When they came back, they were symptomatic. We got a ctDNA, and you can see there's a big jump there, right? So truthfully, this is a bit of a failure on my end because we should have caught them in between there. But I don't remember all the details, but there was something where she kind of was, let's just say, over breast cancer treatments for a little while there, which I don't blame her. But you can certainly see a trend there where obviously when there's a bit of a jump, things become a little more alarming, I'll say. I think there's a few more here. Okay, so this is an interesting one. This is a patient that had 55 positive lymph nodes at time of her surgery. It was lobular, so that kind of fits it a little bit. I think it was 55 to 59, something crazy like that, the highest number I've seen in a while. And she got adjuvant CDK4/6, hormone therapy, and she was compliant, adjuvant Zometa. And we got scans at the start of that in April, and then over the course of a year, trend down to 0. The tricky part here is, do you use this to feel more reassured, or is it really, not clinically significant, or is it just lucky? Hard to say. But certainly, I think there was some tumor shedding or something at the initial phase of this that, fortunately, was able to be cleared. I think she might have been getting radiation in between April and June or something too. But, I think it's just, for me personally, a testament to continue the trend. I've been doing this on her for, basically 2 years now. I guess I'm seeing her in a few months, probably do it again. But I think in her, I think it's reassuring now that if it ever pops up again, it's a bit of an alarm to do more investigation, right? But hopefully not. Oh my God, how many more do I have? Okay, I think I have like 1 or 2 more. This is kind of similar to, not the iSPY study, the one I showed after in the UK. This is a patient that had surgery and then was upstage with her lymph node burden and got adjuvant chemotherapy. Her tumor actually went from ER positive to HER2 positive, so those are always fun. So she was getting adjuvant chemotherapy starting in January. Unfortunately, it's been downtrending. I think I'm probably seeing her in a week or 2 to repeat it, and hopefully it can go down to 0. But sometimes it helps the discussion with like compliance and I'm hesitant to say any more than that because it's not changing treatment per se, but it's just adding context to the situation. So, the fact that it's downtrending is encouraging. Hopefully she hits 0. We'll see. Okay, oh my God, there's 2 more. Holy cow. Okay, let's see. This is someone that had inflammatory breast cancer, was treated appropriately with chemotherapy, adjuvant CDK4/6. And I think why I put this on here was to look at the timeline. So her first positive was in October 2024. And then, she got scans at October 2024. And then when it went up to 1.17, they were negative. And in October, she had lung mets. So the lead time there is about a year, which I would say fits about the general studies with Natera in terms of the or the lead bias time of predicting tumor recurrence. So it's one thing to see it on trial, it's one thing to see it in practice. And then, this patient actually went on the novel regimen, which was a challenge in itself too. And okay, I believe this is the last one. Similar situation to the one I just said, and this is someone that I've been doing ctDNA. This is probably one of the first ones I did, November 2022. And she had been negative for a long time until, you see the jump out of nowhere to 2 and then 10. And, had begun definitive therapy. I believe she was locally advanced ER positive. And, part of it's the timeline there. You can see, once again, my frequency of testing. And then, catching, and, I'll say the last 2 patients also were asymptomatic when we detected them. So, am I adding more toxicity to treatment, or am I, hopefully starting things sooner? I would argue the latter, but again, I understand the argument. But you can see once that jump goes to, let's just say, double digits, certainly more clinically significant, I would say. Okay, so, last slide here, goodness. Sorry, guys. This is not a perfect test. This is not something that I would say everybody needs to get done. And, there are plenty of criticisms that I completely accept from, oncologists all over, certainly locally. And then, if I were to give this talk at ASCO, I would probably be peeing my pants a little bit, right? It's definitely a spicy topic. But I would tell you, it's always just one more piece of information to the whole clinical picture. You know, are there real false positives or not? Does it matter if we can detect to the millionth, billionth, whatever level? I'd say TBD, right? We don't know yet. But, for me, I would argue the trend is a little bit more significant. And, I would still be an advocate for, lead time bias, trying to catch recurrence as early as possible, especially with the, increasing options in the metastatic setting, right? So I think that's it. All right. Any questions? Sure.
Think there's ever going to be a comfort level with potentially eliminating or minimizing biopsies?
Yeah, great question. So the question, I guess for Zoom people, is tissue stewardship. Do we have to biopsy at every recurrence? Can we just use liquid and let that be reliable on its own? I'd say it kind of depends. Certainly we've all sent tissue off to whatever NGS company, then it comes back and the block is totally wrecked, right? Then you can't send any more testing on it. You got to do another biopsy to get, testing for a trial or whatever. And then it's a lot more burden to the patient. So there's a lot of, process benefit to doing liquid. I would still say solid tumor is still the superior test for catching, or for missing less mutations. But especially if we're going to start doing serial testing for liquid, I think that would be more reassuring in terms of trying to catch a mutation. But I wouldn't say it completely replaces solid tumor yet. But for someone with ER-positive disease, I think it would be very reasonable for them to not have to get solid NGS for years and just rely on liquid. For the other tumor types, I think it's a little bit trickier, right? I think when you initially diagnosing, you're probably going to do something on a liver, lung, or something like that. But afterwards, maybe you don't have to. I wouldn't say jump to it totally just yet, but in the next 5-10 years, maybe. Patients obviously prefer doing that over blood draw, over liver biopsy anyway too, right?
But I think there's some things that you can't replace, right? Like sometimes, like Dr. Kurovis, like switching of phenotypes, right?
Yeah.
HER2 null 0 to HER2 1+, and you can't get that information from liquid.
Yeah, absolutely.
I have another question. When you see in a triple-negative breast cancer patient this uptick in the ctDNA, as part of scans, do you also get a brain MRI?
So routinely right now, I don't. So I would tell you the ones that I showed where, it's 0, 0, and then goes to 0.1 and then 5 or something. All these patients were asymptomatic, which is fortunate, I would argue. I would say we don't do routine MRIs of the brain, in adjuvant setting right now, right? Unless they're headaches or vision symptoms or something like that. So right now, I would say no. It's an interesting idea, right? So triple negative or maybe HER2 positive, right? Someone more likely to have recurrence there. So I would say right now I'm not, but it's an interesting thought.
Yeah, I was just wondering because if you're going to do scans, might as well maybe do the whole complete set, right? I don't know. It's more expensive.
It's a fair thought. Theoretically, you have an ER-positive disease too, right? So if the levels is like over 50, do they need an MRI brain too? I don't know. Certainly when you have these things pop up, you run a review systems, is there anything weird going on? And, there's only one person I've had where they had active symptoms, but they kind of lost the follow-up and I don't think I showed it, but their level was like 80 or something. And they had intramucosal disease in their colon, which is kind of weird. So their recurrence was diagnosed on a colonoscopy. So I think the hope with the use of the test is to catch things earlier. So an early asymptomatic brain met is an interesting thought, right? Maybe you can intervene on it sooner. I am not yet, but I'm open to it. But certainly, you ask the questions and see if they have those symptoms, have the need for it.
I sometimes wonder in the TNBC space, especially if it's any effect of the immunotherapy, because we know that can stick around for a while.
Yeah.
That the immune response might be waiting. Obviously, with endocrine therapy, like there's still an adjuvant treatment.
Mm-hmm.
I was also going to ask you, I haven't come across this as much in breast cancer, but I've had a couple people on consults who say have Lynch syndrome.
Yeah.
And you can't really, like the testing is very frustrating because it's going to come back positive, even if they don't have any disease. I'm curious if you've heard from any companies yet, maybe the thought to personalize some of these assays further where you can kind of
I went through this with that first case I showed, the BRCA2, like how is this level 2 when someone that had a T1A tumor, triple negative, got chemo? So I don't believe they have that yet. And my hope is that as they get to more minute detection, that they're able to separate it out a little bit. I think a lot of it depends on the initial tumor analysis they do when they get the sample. I'm not a microbiologist, so I'm sure on the scientific side of things, from the company side of things, they're looking at those things. But I think their argument would be there's enough there for the vast majority of patients to detect recurrence. And when you get these unique situations of genetic mutations, high-risk tumors, biology, or incomplete response to chemo, it's pretty niche. And fortunately, my one case here, long term they did, fortunately go down to 0. Not to say that's gonna be every case with depending on mutation. So I don't know, hopefully, but it's tricky, right? Because then use of those tests in those patients, you got to bring it up, right? Like you may be more likely to have a false positive, more likely to have more screening that you don't need, right? A lot of those patients will tell you they're reassured to have the scans that are negative, right? So, it just depends. Part of the discussion. No right answer from my end. All right, thanks everybody.